Much for joining Dar and I for this breakout session. It's entitled Rising to the Challenge, Incorporating Inclusive Language into Medical Education. And Star and I were both part of the APGO Diversity, Equity, and Inclusion Task Force. And this really came out from the work that we did there, our desire to share this information.
Hi, everybody. Welcome. As Shireen said, we're really excited to have everybody here today. We are working through a few technical things that we're thinking that we're going to work for us, but may not be working. So just give us some grace this morning. We're really excited to have everybody here. Shireen, do you want to introduce yourself and then I'll introduce myself?
Yes, I'm Shireen Madani. I'm from the University of Florida in Gainesville. I'm a recovering clerkship director and now the vice chair of education for my department and the assistant dean for student affairs at UF. I'm also a UMEC member and really happy to see Sue and Maya and some other UMEXers on the call. Thank you.
Hi, everyone. I'm Star Hampton, and much like Shireen, I'm also a recovering clerkship director, one of my very favorite jobs of all time. I'm also vice chair of education for my department of Ob-Gyn at Brown Women and Infants in Providence, Rhode Island, and chief education officer for our health system there. So I'm really, really excited to be here today. I think one of the things that we are all excited about for FDS is the networking that takes place, which is a little bit challenged with our virtual platform, but we're hoping to have that happen for us today. So along with our introductions, we were hoping that you could put your name in the chat, where you're from, and your email address, because we are hoping to have some enduring products from this workshop that we can then email everybody when we are finished with our workshop today. So if you could introduce yourselves with your name, where you're from, and your email address in the chat, that would be super helpful. Thank you, Holly, for doing that. So, oops, sorry. Next thing that we really wanted to talk about today is that a lot of what we are discussing this morning are things that we're still working on. We want to make sure that this feels like a safe space for everybody this morning, and that we give each other grace, as I said, not only with our technical issues, but with the subject matter at hand. Part of that is that something that I just did was by calling Holly, is that we will be using first names today, hoping to just make this a more comfortable and relaxed environment. So hopefully that is okay with everybody, that we will be using first names, true to FDS and true to the spirit here. And thanks to everyone. If you're late with joining us or a little bit behind in joining us, if you could just put your name and where you're from and your email address into the chat. So something we want to remember is that words are powerful this morning. And that's what Shireen and I are going to be talking about, right? Is the power of words and the power of the words that we use when we teach our learners. We also really want to make sure we remember that our learners are way ahead of us on this, and we are all still learning and still adapting. And every day is a learning experience for us when we think about inclusive language and when we try to incorporate inclusive language into our daily lives as educators. So really just remembering how far ahead of us our learners are in this, and listening to them and taking feedback from them, but really remembering that everything that we say, everything that is in our teaching materials, and our words as well as our actions really have a lot of power.
So when we think about sort of defining inclusive language, we want to start out with sort of a definition so that we can make sure we're all talking about the same thing. But inclusive language is really thinking about language that avoids the use of certain types of words or expressions that might exclude certain groups of people. We want inclusive language to be accurate, unbiased, respectful, and most importantly, consistent with the communities being discussed. It really needs to be people first and, placing the person before their condition. And I think we need to understand that this may be a work in progress and may be changing. Some examples, a lot of us, as we're first starting to have these conversations about what inclusive language looks like, we don't even know what types of words to try to replace. And if we do replace them, what are we going to replace them with? So an example here is when talking about disability. So instead of using words like disabled or handicapped or differently abled, you could use terms like people or person with a disability. You could be specific, people who are deaf or hard of hearing, people with intellectual or developmental disability, people who use a wheelchair or mobility device. So sometimes being very specific can be very helpful. And there are a lot of different resources that can help you with this.
So I think this morning, part of what is so great about APGO FDS is, again, that interactivity, and we're going to try and recreate that virtually this morning. So first of all, if you are able to come onto video, that would be wonderful, so that we could see your faces and so that we could meet each other that way. But we really wanted to hear from you about what some of the experiences that you may have had about incorporating inclusive language into your learning environment. Or if you're a learner, what experiences you've had with inclusive language or language that may not be inclusive for you. Etc. So, I think we are a relatively small group today. If you want to come off of mute, please do so. But otherwise, Shireen and I are happy to take some comments and read them from the chat as well, if you put some comments into the chat. But we really wanted to understand what some experiences were that you've had with incorporating inclusive language into your learning environment. Yes, I see a hand up, I think. Go ahead and unmute yourself if you want.
Hi, I'm Holly Cummings. I'm at the University of Pennsylvania. I'm the clerkship director there. And one thing I've been struggling with over the past few years is referring to our patient population exclusively as women. I have actually had a growing patient population of trans patients. And so I recognize how important it is to include them when we talk about our patients. But at the same time, it is an OB-GYN rotation. And so without making every time we say, the OB-GYN rotation, something turning it into a really long, wordy kind of introduction, I did notice there was some email that I got from SASCOG recently that used the phrase that I really liked, and I've actually adopted it, but it says, healthcare for women and gender diverse people cared for by obstetrician gynecologists. So that's something I've been using.
Really great example. Thank you, Holly.
Holly, we've had this issue at our institution, and in talking to others around the country, there was at least one school where the students thought that women should be referred to as person with uterus, which doesn't really fix the problem either, right? Person with uterus. They might not have a uterus, right? At any time.
Other thoughts on that, or other comments?
I will say that in APGO, with some of our learning materials, specifically thinking about the teaching cases with UMEC and the UWIs and Prep for Res questions, we really just kind of made a decision up front that we were going to use woman and she, her pronouns. And we put this on our website. We explained why we did it. And for our education materials, our thoughts were really that we don't want to cloud the issue or make students have to take a step back and say, now, who are we talking about and what are we talking about? We want to really focus on what is the education topic that we're trying to teach today? What is the point that we're trying to make? And we have not received any pushback from students. We do get a lot of feedback from our learners, which we love, and we make adjustments based on that. But thus far, we have not heard from any of our learners that they're bothered by that.
Other challenges.
Maya, I know you were involved in those conversations. Do you have anything to add?
No, can you hear me okay? I'm sorry, I have to say, can you hear me?
I think
Yes, Maya, we can
Uh,
hear you.
we can
Yeah,
hear you.
yeah, I'm sorry, because I'm in the car and I can't turn my camera on, but I think that just to add to what Shireen said is also some of our exams are used by international students, which might not be completely understood by them because it's not something that has gone internationally. But we do have some questions that are, if there is actually a specific reason to state why it's different than a woman, then we do have questions on that. So we have not excluded that part of it because we do have other questions that focus on specifically some other transgender patients and patients who well, we're not referring to, and we'll refer to their pronouns, whatever they are, but the question is about the care for them.
Thank you, Maya.
Other challenges that people are finding with this or
Other than
experiences that they've
woman.
had. Abhishek?
Raise hand, Abhishek, yes.
Can you guys hear me?
Yes.
we can hear you.
Okay, sorry, I had a little bit of technical difficulty. So I'm one of the fellows from Brown, actually, and this is sort of in that same vein. Do you guys have, I gave a lecture to the medical students actually yesterday or 2 days ago on urinary incontinence, and I was sort of in the back of my mind trying to avoid using the word woman, and it seemed like very strange to me that I was doing that. Do you guys have like a phrasing that you start your talks off with that, you refer, throughout the course of the talk, you're going to refer to, either women or people with uteri or some sort of set phrasing that you like to use?
Yeah, Abhishek, thank you so much. And Abhi is my fellow who's awesome and going to be giving a round table later today. I'll just put in that plug. But in any case, yes, we're excited. First time FDSer. So I recently gave a didactic lecture, which I don't often do, but I gave a very large didactic lecture to the medical school for our HRGD course. And it was the first time, Abhi, that I used the sort of introduction that I was going to be using the word woman, but that I absolutely understood that not everybody, with a uterus identifies as a woman, and not everybody that is a woman has a uterus. And that for the purposes of the lecture, if I do use the word woman, I was giving a menstruation lecture, so I was talking about women with uteri. For the purposes of that lecture, I was using the word woman meant somebody with a uterus.
And thank you, Maya, for adding in the chat that they do the same for their talks at Michigan.
Yeah, but I do think that, starting any lecture with a disclosure slide like that or a sentence like that just allows your learners to understand that you at least are, aware of the fact that the word is, may not encompass everybody that we take care of, and that you understand that certainly, not everybody that's a woman or identifies as a woman has a uterus, etc. Or was born with a uterus.
I've pretty seamlessly transitioned to just saying patient and person and people. So, the pregnant patient, the Ob-Gyn patient, the patient with urinary incontinence, whatever, and then using they as a singular pronoun without saying, without drawing attention to it. I think because my own patient population has changed so much in the last couple of years, I've just transitioned to doing that in other settings pretty easily, actually.
It's a really good point, Holly.
Yeah,
Sue, I like your idea. It would be nice if APGO UMEC developed a universal disclosure slide. It's a great idea.
that is a great idea. It's a really great idea.
Yeah. If Sue actually did send to us the MBME guide for how to refer to patients, and I really, really like it because it does go through the point of how you need to, and it talks not beyond gender also, about ethnicity and all this. And I thought they did an amazing job. Sue, I don't know if that's available to circulate to everybody or not, but I think that's a really, really useful guide, because the examples they use are amazing in terms of how they say when you should say something and when you shouldn't, and why, what is the reason.
Well, Maya, it's like we planted you as the transition to the next part of our talk.
These
Because
are-
Oh, you're welcome.
I'm going to just advance our slide here to what resources there are that exist. So early in the chat, if you guys will scroll up in the chat, I did put links to these because we do want you to be able to refer to them and have link out to these resources. I did want to bring in the documents for you, but that's where we had a little bit of some technical difficulty with bringing in documents. So, you know, now that we have everybody's email address in the chat, and if you haven't put your email address, please do so. We will certainly email out our documents as well. Abby, you keep raising your hand. Is that a something you want to say, or is it a technical glitch?
It's an old raise.
It's an old raise. Okay, so we'll go ahead to Shireen's resources, beginning to talk about some of our resources.
So one of the resources, all of these are in our syllabus materials and posted links, but and Holly, I agree. Star, I'm not seeing those links in the chat.
Okay, I will put them back again.
Yes, again,
I will repost them at some point.
Thank you.
Right now, actually.
So the CDC has some really good information with their health equity guiding principles for inclusive communication. Next slide, Star.
Sorry, I'm doing two things at
Okay.
once. Go ahead.
And, you know, they have lots of different ways to think about diverse communities and, you know, things going on beyond race. And what I really like about the CDC version is that it's very accessible. Like this makes sense to me. It's easy to read. I can search. So for example, instead of, you know, if we're talking about the topic of homelessness, instead of saying homeless people or transient populations, you could use Holly's word, people or persons, people experiencing homelessness or unstable housing or unsheltered homelessness. And to describe people of lower socioeconomic status, you could say something like people with lower incomes, rather than using words like poverty and poor. So just being really thoughtful about how we do this. And I've even seen others extrapolate beyond that, lower socioeconomic status due to X, Y, or Z, or whatnot. That's good, Star.
So the CDC, I did put that link in the chat. Hopefully everybody can see that. The link to this, this resource is also in the chat. This is the AMA resource. So it's Advancing Health Equity, Guide to Language and Narrative, Language, Narrative, and Concepts. So this is really exciting. This is a much more in-depth document, a PDF document that also has tables like the one that we are pasting here as an example of a commonly used term, and then an equity-focused alternative, and then reasoning behind that. So, you know, I find the CDC document really accessible. You know, I have a term, I want to substitute it because I realize that this term may not be person forward or inclusive. So that the CDC is great for that. This gives you a little bit more background and information, and goes into a little bit more in depth to reasoning, especially if you want to have justification when speaking with faculty that are a little bit more resistant to this, et cetera, or really just, you know, learning for yourself. And then another really great part of this AMA guide is this glossary of key terms that will define terms for folks, and really is very helpful when you're thinking about terms and concepts that are very frequently used in equity discussions. It's also, you know, as described in its front matter here, it's a really nice starting point for reflection. And clearly, just like everything that Shireen and I are saying today, we're absolutely not being exhaustive, but this is just a list that you can start with.
So if you were to do sort of a Google search or some sort of search to try to find out what resources are out there, you actually will find a multitude of different resources that can be very helpful that are put out by different groups. I found this group, the LGBTQIA glossary of terms for healthcare teams, to be particularly helpful with describing terms that I'm hearing a lot, especially as Star mentioned at the beginning. Our learners are really at the forefront of bringing this to our attention. But especially if you're at the beginning of your journey and trying to learn what some of these things mean and how to properly use them, this type of glossary can be very powerful. It's important to keep in mind, though, that to give one another grace, to give us all grace, because these words are changing. And I think we can anticipate that they'll continue to develop, and sort of best practices or common usages will be more and more evident over time.
And this link is also in your chat. So this is a really awesome resource that, again, I wanted to pull into the chat, but I wasn't able to, but we'll certainly email this out. So basically, this was published in Academic Medicine, and the work that was done behind this was that a work group looked at patient teaching cases, and they basically developed a guide for how to revise the teaching cases. And so basically the guide focused on 6 main themes that they found to be prevalent, that were basically common mistakes in these teaching cases. And then what they did, is they basically built a toolbox or checklist of what to use when you're building teaching cases. So for example, one of the pitfalls that this work group found was that very often racial and ethnic health disparities were not identified as caused by social and structural determinants of health, but they found that were in the teaching cases that were reviewed, they were really more identified like genetics or biology, and they wanted to shift that to being caused by social and structural determinants of health. So really thinking, then does your case include these 4 check marks so that you avoid that pitfall, right? So were references to race and or ethnicity as risk factors for disease, was a patient of color and or was the patient a patient of color and or a minority ethnicity, et cetera. So definitely suggesting edits and thinking about what to look for when you're writing the cases and reviewing cases. This is a really awesome resource and toolbox, and we will send this out.
So in the Journal of Midwifery, you can also find this editorial about inclusive language and the power of words. And it's important to know that there are other healthcare groups that are working on these same things, and they may have differing opinions or similar opinions. They may address different issues than what we're particularly addressing. But again, there's a multitude of resources that exist. And some of these could be used, as a handout. You could share with your department members as they're trying to create and review their own curricula. This is the PDF I was referring to. So using language that reflects who is the center of our care. This is a nice sort of 1-sheet summary of the paper that Star referred to from Academic Medicine, and we have that in our resources as well. But it's really giving you some ideas about replacement terms and reasons why. And this would be something very easy to share.
Yeah, this is such a nice little PDF that you can even post places.
Mm-hmm.
If you have a bulletin board in your clinic or something like that in your learning spaces, what a great little handout that you can print out and have posted in your learning spaces.
And we're putting Sue Cox to work already. She's added these resources to the Whova link. Thank you, Sue. You're awesome.
You are awesome. Thanks, Sue. Shireen and I also have some things in our syllabus materials. I'm forgetting exactly what we sent for that, but we will resend everything as well. I'm going to give a shout out to my educational faculty development group at Brown, Alpert Medical School, led by a very talented woman named Emily Green. Our website's really quite comprehensive, and we have and I put this in the chat as well, the link to this website, but we have resources for inclusive teaching as part of our website for educational faculty development. So examples of things that are on that are this, again, a really nice PDF that you can print out and place in your learning area to have anti-racist clinical case documentation tips. So, do not label patients obese, but patient with obesity, et cetera. Use the patient's perspective. So this is very similar to the AAMC last page PDF that we referred to just a slide or two back. And then this has been really, really useful. And I will certainly circulate this to everybody. This is also basically a checkbox and toolkit for how to create inclusive criteria. And you can, if you go to the website that I pasted in the chat, you can pull up this PDF, both of these PDFs very easily. You don't need to have a sign in or anything. It's accessible to the general public. But this is really a great thing to use. And speaking of disclosure slides, I do ask faculty at my institution to use a disclosure slide before their didactics that say that they've referred to the Brown AMS Creating Inclusive Criteria Toolkit when they put together their lecture. So that disclosure should be on the top in the front of their didactic content. And then I've actually added to the student or resident evaluation form a checkbox. Did the faculty member disclose that they use the Creating Inclusive Criteria Toolkit when they gave this lecture? So that is also part of their evaluation form, so that if I'm not attending every lecture, I can at least keep an eye on who at least disclose that they use the toolkit, which is the first step. And then reviewing, of course, the content of their didactic is the next step, but making sure that they've tried to make it as inclusive as possible by using this toolkit is what we are hoping for. Any questions or comments regarding, I just wanted to pause here regarding the resources that Shireen and I discussed. Some of you may have other resources that you use or think are really incredible, which we'd love to hear about, or maybe you want to put them in the chat if that's possible, or even send them to us and we can circulate. But any comments when we pause here? No? Okay. So we'll go on to the next part of our talk, which is where we became a little bit flummoxed in our with technology. So what we wanted to do in this next part is we are going to I'm going to put us into 2 breakout rooms. So hopefully that's part 1 that will work. In each of those breakout rooms, we'd love for you to just introduce yourselves to each other, make sure you know who you are. If you could choose somebody to record or type on a Word document your work or final product as you work through it, that would be terrific. And then get to work. So basically what we would like folks to do is write and choose an educational topic, which this is the part where we got flummoxed. We were going to have you each have a document in your breakout room, but we weren't able to do that. So we are going to, Shireen will be in one breakout room. I will hopefully be in another breakout room, and we can we're going to have an educational topic. And then what we want you to do is, as a group and using inclusive language, write a clinical vignette for the educational topic that would be used to maybe kick off a case-based learning session, a clinical teaching session, or even act as a question stem for an exam. So you can really pick what you want to do with this, but it's basically writing a clinical vignette based on the educational topic. You can certainly use the resources that Shireen and I have discussed if you need to. And we have a couple of educational topics. It looks like we have probably about, what do you think, Shreen, 15 minutes to do this?
Yeah, about 15.
Yeah, so we have
That's right.
about 15 minutes to do this. So I will have us
Come back
auto
at 12 maybe, or 12.
yeah, I'll have us auto close the breakout rooms after 15 minutes. So I'm just going to put that in my breakout room here. And then we'll talk about, how it felt to really work through these topics. So I am going to open all rooms at this point. I think I've assigned everybody to a room, which is great. And I am going to hopefully get you to a room. So if this doesn't work, it doesn't work, but I'm going to try and do it. Okay, we're giving each other grace this morning.
Going to 2. Time. And with my second group, we did not actually get to write a case, but we had a very good discussion
Good.
that I think we
Perfect.
can share.
Perfect.
And I don't know how we left the first case. I left Sue in charge.
Wonderful. Well, Sue's always great to be in charge.
Yes, yes.
And I was trying to figure out how to share my screen and be in rooms, which I wasn't able to figure out. So therefore I didn't do that.
Yeah.
But so Shreen, maybe do you want to kick off the discussion then, since you were in the rooms?
Sure. We let everybody in.
Yep, I think everybody should be back at this point.
Oh, I'm sorry. Okay, yeah, there we all are. Okay, so welcome back. That went by really quickly. And again, we have had some technical problems. And in room 2, we actually did not write a case, but we had a great discussion, which I think we could share. I'd like to share. And so we decided we were going to write a case about ectopic pregnancy. And that led to some further discussion. Robert, do you want to share what you brought up?
Sure. So I think in the process of us moving forward and writing the case, we identified a G1 patient and then began discussing her history. And it just prompted questions about like whether it's quite okay to create the patient, knowing that there's no objection from the written document on the paper, but create the patient with some consistent assumption about that patient's self-identification. So can we write the case as a G1 patient with her history having this without more and more clarification for gender identification, for example, by the fictional patient that we hadn't had the opportunity to ask about what their gender preferences were. And then we had several comments about how can we write a case that can be medically appropriate and useful from a learning objective standpoint in a way that is inclusive and not offensive, I suppose, to any of the readers that could be just trying to learn the medical aspects.
Melody, you had some good comments as well. Would you be able to share?
Yeah, I think where we kind of struggled was that as we identified, G1 ectopic pain and bleeding in our discussion amongst ourselves, we kind of moved automatically into gendered language. Well, what's her history and what complications do we want to give her as far as risk factors? And I think that's what prompted this kind of discussion of whether or not this was the quote unquote right way to frame this case, and whether or not we could just assign a gender to a patient and whether that was okay. And I think the point that we had some consensus around is if we're building a case, we can build a case with a gender identity, whatever we want that to be. But then it's also important kind of in that opening statement to include the patient identifies as X, so that it's not just assumed how we're moving forward, or the patient is a trans male that uses he, his pronouns, and then move into the case, so that we are allowed to give our patient a gender identity. It's just how the language that we use around that should be as inclusive as possible.
I love that, Melody, and I love including that as part of the case, that you've discussed this with the fictional patient, and this is how they identify. And then I think just making sure that when we do have cases, if we have 10 cases, that not all of our cases identify as she, her, right? So that we have as inclusive a grouping as possible that mirrors the population that we take care of. I don't know if others have comments about that.
It was interesting because one thing that we sort of had to address and acknowledge in our particular case, because it was ectopic pregnancy, it needed to be a patient who was physiologically capable of becoming pregnant, whether they're she, her, or, whatever the pronouns or identity would be. And, we could really change that up a fair amount. Sarah, did you have anything to add? Sarah was our typist. She was our tracker.
No, I think Robert and Melody actually did a pretty good job, because I think there's a lot of ways to go about it with pronouns, or trans or cisgendered or that sort of thing. But I also think you have to kind of streamline it, because as Robert said, a lot of our the people that are going to be reading and learning from these cases are also focused on the medicine at the other end. And I think, you're balancing that tension. So we had a good conversation about it.
And I think just being open, like when we started this, Robert, kind of brought up his thoughts, and that really changed the trajectory of our conversation, I think, in a really great way. And so I think if we as educators, and if we as people who are presumptively leading our departments and maybe our institutions in creating education material, if we can just be thoughtful to listening to other perspectives and to kind of recognizing that this may be a work in progress, there may be things that change here, but our learners especially are going to bring this up to us. And so we need to, I know at our institution, we've had some issues with, faculty not really understanding why this is a big deal. So we need to be at the forefront of listening and of inclusivity.
Definitely at the forefront. And again, that's where some of the documents like the AAMC that has some, reasoning behind why these, the change in inclusive language is so important, can be helpful in those situations.
Sue Holly
is in your room. Yeah.
And Cecilia was the timekeeper over there, or the writer.
Yeah, Holly, you want to lead the discussion?
Sure. So our case, we chose the topic of third trimester bleeding, and we're going to create a vignette where the patient has used cocaine leading to a third trimester abruption. And so we wrote it, I think Cecilia has it written down, but I believe it was something like a 32-year-old G5 P4004 patient at 33 weeks, presents with bleeding. And then we went with phrasing. I don't know, Cecilia, if you want to just read it.
Yeah, sure. 32-year-old G5 P4 pregnant patient at 33 weeks gestation presents with abdominal pain and vaginal bleeding. Patient reports pain began 3 hours and continues to worsen. The onset of bleeding began in the past hour, and they have not felt the baby move. Past medical history, significant substance use disorder. But there was a she originally.
There was a she, right? And I think.
And then we rewrote it to say they, and it sounded fine. But yeah, I was on the same camp as Holly, that when she mentioned earlier in your presentation, I use patient as well. Patient or partner, I just avoid the pronoun unless I actually ask it completely. But, I did notice, like with the upgrades in the cases for APGO, even they'll put the pronouns after patient for all the cases. So I think when it comes to creating the cases, just even having that there helps the reader understand that you're trying to be inclusive, right? Like you're including that information.
Totally. And then I think, this group is informed, especially after the past 50 minutes, but using substance use disorder versus, drug abuse or, et cetera, or a
Cocaine
39-year-old drug cocaine user,
Yeah.
right? So you use person first language throughout that.
Well, and I think also, what is the learning point? So the learning point, I think, was that cocaine use in particular can be identified as a risk factor for placental abruption, right? And how to sort of divorce that from any other meanings.
Yeah.
Other than that association.
I'd like to make just a comment, way too big to cover in like 1 minute, but I think this is important to know. Sometimes we're teaching these medical topics, but through a lot of exposure, our students are learning how to communicate with other professionals. Like they're picking up the phone and they're communicating the ectopic pregnancy patient to the OB-GYN because they're an internal medicine doctor. So they're learning how to do handoffs essentially through these same kind of case vignettes and how we discuss in the wards. I guess the concern I have with a little bit of this is that this same language goes into our notes. And when a patient reads their note about how their doctor took care of patient, and patient had complaints, and patient had this, and we did this for patient, when the patients read their own notes, that becomes a very cold and callous relationship that you're developing with them. I have taken for years the habit of referring to Miss Jones. Of course, the Mr. and Miss thing could be challenged at some level, but rather than calling patient, I identify the patient better by name. Some people use first names, for example. I just think we just have to also be careful that we are not inadvertently depersonalizing the patient from the communication and the documentation. Through years of going through these vignettes that the students learn how to communicate about these individuals, this could end up backfiring a little bit and depersonalizing the patient from our relationships with them through the documentation. I just thought that's just a worthwhile thing to mention, because the patient is a very nice way of getting out of the whole gender thing, but inserts a level of depersonalization into our documentation that we have to be careful of.
I agree. And I think, what's different in these vignettes versus, for instance, like when I communicate with someone in person, I'm establishing what are their pronouns, what are my pronouns. And then in a patient's chart, I'm using the terminology that they want. So if a patient says, hi, I like to be called, Emily, then I'm writing Emily said this, Emily feels their, her pain is whatever. But if I'm in a situation where I don't know, then I go with what's safe, which is gender neutral. And I do think that's fair. I also think the Mr. Miss is like, that's tough. I don't want to be Miss.
And then you have your regional things, like in the South where I am, that's a thing. People want to be called, a lot of people want to be called Ms. or Mrs. And, I'll get, I'll even sometimes ask, I always ask, what do you prefer to be called? And
I think that's the important piece, is that you're asking
Yeah.
patients and then you're documenting that correctly, based on them.
Bonnie needs to close the meeting. This is such
Yes.
a great discussion though. And I really thank you for your participation. We have emails. We will email out those, some of the things that we were unable to get into the chat today because of technology. I'm sorry that we weren't more facile with that, but we really appreciate your time and look forward to a great meeting.
Thank you so much, everyone. Bye-bye.
Great session.
Thanks, Sue. Thanks for being here.